Welcome to the NEI podcast. In recognition of Domestic Violence Awareness Month, we are re-releasing episode 63 on traumatic brain injury in victims of intimate partner violence, hosted by Dr. Sabrina Siegel.
In this episode of the NEI podcast, we are discussing intimate partner violence and traumatic brain injury. I have here with me today Deb York, a psychiatric mental health nurse practitioner in Colorado Springs. Welcome, Deb York.
Thank you, Dr. Siegel. Good morning. Thank you so much for the invitation.
Welcome. Thank you. My first question for you is that when we talk about intimate partner violence, could you describe for us or explain to us exactly what we mean when we talk about an intimate partner?
So this, very broadly defined, is a person who has a close personal relationship. And this can be characterized by many, many things. Inclusive, though, we look at an emotional connection. We look at regular contact. We look at an ongoing physical contact and possibly even sexual behavior, sexual relationship as well. To identify as a couple potentially, and the familiarity and knowledge about each other's lives. The relationship does not necessarily, of course, need to involve all of these dimensions, but those are characteristically the top, say, 5. In intimate partner violence, though, this is a domestic violence by a current or former spouse or partner in an intimate relationship. And it's against the other spouse or partner. And it can also take many different forms. So this is inclusive of physical, verbal, emotional, economic, and sexual abuse. The CDC actually divides domestic violence into 2 types. So reciprocal, in which both partners are violent, and non-reciprocal violence, in which one partner is violent against the other.
Wow, that's great that you made that distinction in terms of the different types, because I think it's important to look at that, that a lot of times there's common misconceptions about this topic, and it's great that you shed some light on that. We are aware that intimate partner violence is more prevalent in our country than people think. There's approximately 10 million annually, and yet only 35% receive medical care for their injuries. Why do you think that is?
There are 3 top reasons, in my opinion: the fear of reporting for potential further retaliation, the lack of education and screening in this population. This includes sparse resources as well for diagnosis and treatment. It is that cycle of abuse that is then propagated by serious repetitive injury. And if someone enters the emergency room, for example, and has a temperature, immediately a complete blood count and complete metabolic panel are drawn. And when someone who has an injury from an intimate partner, they may enter the emergency room with the perpetrator. The one may have brought them in for treatment. There are potential legal complications, children involved. It's a multifactorial canvas that's never the same color. It is also difficult to recognize intimate partner violence. These people don't walk around wearing a sign that says, "My partner is abusive." If you think about it differently in more simplistic terms, 1 out of 4 people eat fast food every day. 1 in 4 women may be a victim of IPV every day. So it's both men and women, and they have a better chance of being victims of intimate partner violence than being left-handed or having blue eyes.
Wow, that's shocking. What is the most commonly reported injury when it comes to intimate partner violence?
In some studies, Dr. Siegel, over 90% of injuries occurred to the head, neck, and face, a pattern of violence leaving survivors vulnerable to traumatic brain injury. It's not football practice. There are no pads and helmets in this population.
Those results seem shocking as well. So with that being said, how many women report experiencing at least one intimate partner violence related traumatic brain injury, and how many report multiple intimate partner violence related traumatic brain injuries?
Dr. Siegel, that's a great question. Dr. Eve Valeria, who's an assistant professor in psychiatry at Harvard, has performed extensive research in this area. One of her studies took place at Mass General Hospital, and it was profound. 75% of a sample of 99 women who had experienced intimate partner violence sustained at least one partner-related traumatic brain injury, and 50% sustained multiple partner-related traumatic brain injuries. Since some of these women in this study suffered from repetitive, mild traumatic brain injuries weekly over years, sometimes in the form of an anoxic or hypoxic injury from strangulation, which go virtually unrecognized by both the women and caregivers. This is in contrast to other populations such as sports players with a single traumatic brain injury or accident victims who are often aware of their traumatic brain injury and modify behavior accordingly to resolution of the initial sequelae for each traumatic brain injury.
What could be done by clinicians to raise awareness about this situation and to make sure that this forgotten population does not continue to slip through the cracks when it comes to treatment?
Yes, this is the challenge. I think as clinicians, we need more accurate and appropriate screening tools and assessments, asking the appropriate questions in the appropriate environments, and offering examples that allow patients to include events that may result in a traumatic brain injury in this population. Really making sure the patient has a safe environment to express and disclose this information is pivotal.
So would you say that some patients find it difficult to maybe open up about these situations, and so that is a key element when it comes to screening?
Absolutely. I would say that the majority of patients are fear-based, and the fear of retaliation is probably number one in this environment.
Understandably. Let's talk about the neurological consequences of traumatic brain injuries, or TBIs, in this population versus the types of brain injuries that are commonly experienced by athletes or military populations. Could you share some specifics with us?
So in athletes, there are blows to the head with objects thrown potentially against a wall or a solid surface, falling or hitting the head. In the military, potentially being punched in the face or head, or being shot in the face or head. Clearly, there's explosions as well. These injuries sustained have neurological damage to underlying tissues, vessels, and are typically focal and diffuse damage, such as contusions, bruising, and bleeding, with disintegration of brain tissue. And in contrast, intimate partner violence typically involves violent shaking of the body, in addition to being strangled, near drowning episodes. This causes neurological damage involving diffuse axonal injuries, so torn nerve tissue, as well as diffuse damage in the event of a hypoxic sustained type injury. So what does this mean? In traumatic diffuse axonal injury, the damage is actually to the axon itself. So this trauma may be focal, multifocal, or diffuse. And Dr. Siegel, I don't personally feel like we really respect how delicate the brain really is and how prone it is to damage from mechanical forces, really associated with the rotational and the linear acceleration-deceleration injuries because of the brain's large size and weight relative to the body and the high ratio of white to gray matter. So the axons in the white matter are especially susceptible to acceleration, deceleration injuries or counter-coup injuries because of the vasoelastic nature that's involved. This kind of injury enters into a very complex system, into the microtubules, the neurofilaments, where there is several mechanical injuries potentially. This produces a complete transection of axons as well as a disruption in the blood vessels and in the glia. These injuries, the traumatic shearing forces causes a cascade of events such as increased membrane permeability in the blood-brain barrier, marked influx of calcium, swelling of mitochondria, disruption of microtubules, alterations of axon transport, and then the accumulation of the cytoskeletal components that manifest into axonal swelling within 3 to 6 hours following injury.
Wow. So with that being said, we know that there's been much focus on chronic traumatic encephalopathy, or CTE, in athletes, primarily in NFL football players. What is CTE?
Dr. Siegel, CTE is a complex neurodegenerative disease, and it's consistent with traumatic brain injury associated with IPV in that the microbleeds are from repetitive hits. We now know that CTE is not just from concussions, it is the repetitive hit of the head that creates tau proteins. So for every 2.6 years of playing football, the risk of CTE doubles.
Wow.
CTE risk doubles after 3 years of playing football. And at the University of Boston, the work of Dr. Stern and McKee, they've actually found markers in life from the cerebral spinal fluid that is still under research. Mm-hmm. And they've been able to find these protein markers of patients who are potentially at risk of CTE. The tau pathology is involved. There are 4 stages of chronic traumatic encephalopathy, and they involve different parts of the brain. Specifically, the neurofibrillary tangle, or the NFTs, are a hyperphosphorylated tau protein. And these proteins on neuroimaging actually show up as microhemorrhaging areas of the brain. So you can now, in very specific microimaging techniques, find these tau proteins. In stage 1 of CTE, tau is found in these clusters, often in the superior and dorsolateral, superior frontal, septal, and temporal cortex of the brain. Stage 2 commonly goes into the frontal, temporal, parietal, insular, and septal cortices. Stage 3, we're looking now into the hippocampal, entorhinal cortex, amygdala. These neurofibrillary degenerative tangles are widespread at this point and involved in the frontal, temporal, parietal, insular, and septal cortices. And then in stage 4, they are dense. These NFTs are widespread throughout regions of the brain with prominent neuronal loss and gliosis of the neocortex. The increasing tau is profound. The hippocampus, cerebral cortices, and increasing myelinated fibers and axonal loss in the white matter then creates the issues related to the behavioral problems associated with CTE. These behavioral problems really start off as chronic effects that involve cognitive defects, starting with significant mood impairments, disturbances, including deficits in executive functioning. There's a 3-fold increase in depression with 3 or more concussions. There's anger, agitation, irritability, even pseudobulbar effect has been seen in this population. Short-term memory loss, in addition, has been one of the stage 1-2 findings that is very frustrating for patients.
Thank you for explaining that. And I know you touched on this just a little bit just now, but what would you say is the proposed mechanism of CTE? Is there one specific brain injury that could cause this, or is it something that's more widespread?
Again, we once thought CTE was a concussion or just one simple hit to the head. And we now know, with the extensive amount of research that's pouring out related to this topic, that it is the repetitive hits to the head. Multiple TBIs cause this, and the proposed mechanism is diffuse axonal injury, just as it is in intimate partner violence type injuries.
So then, given that diffuse axonal injury is the major proposed mechanism for CTE, how likely do you think this population is to develop CTE? And are there any research studies that focus on CTE in this population?
There are only to date 42 published scientific studies, evidence-based, that have examined intimate partner violence related to traumatic brain injury, and 0 that have actually examined chronic traumatic encephalopathy in this population. So it's a vast, wide new area for examination. And I think in the new technology that we have in neuroimaging, that's going to start to really increase diagnoses in this population and certainly treatment.
When it comes to detecting the particular mild traumatic brain injuries in this population, are there specific neuroimaging techniques that you would recommend and why?
There are so many different neuroimaging techniques out there. So this is a really great question to examine because there's really no gold standard per se to definitively rule in or out the presence of a traumatic brain injury using MRI, especially mild traumatic brain injury. And these imaging scans often lack the sensitivity to detect brain abnormalities that result from this type of mild traumatic brain injury. And typically, that is what is sustained during intimate partner violence. Now, you asked the question, what do I think would be the best way to image the brain to find traumatic brain injury? There is new technology out there, and that's what I'm going to discuss today. The work that I have done with Dr. John Sherman at Colorado Springs Imaging, he's a neuroradiologist. We have used an imaging system called NeuroQuant MRI, and it includes multiple different studies depending if we use gadolinium or not. So the specificity and the sensitivity of the scan is higher than a standard MRI. The analysis shows areas of the brain involved in atrophy in addition to multiple reports showing the specificity of 2 standard deviations below the mean in certain brain regions. So the report includes 47 brain structures that are evaluated for the right and the left hemisphere, sorted by lobe and region. And it's a really amazing report. You can read it quickly and really key in on these specific areas of the brain that are looked at in traumatic brain injury. So as part of this scan, there are diffusion tensor imaging. The abnormalities are really beautiful to look at, but they're not necessarily that specific. And they do show, with that being said, conditions such as demyelination, axonal pathology or loss, gliosis, or loss of damage of the glial cells, inflammation and edema. And then there's also a susceptibility weighted imaging report. This report shows increased sensitivity for paramagnetic blood products such as the deoxyhemoglobin, intracellular methylglobin, and hemosiderin, which when the T2 weighted images show a signal loss when hemoglobin is found in these images. So these actually show up in traumatic brain injury as these little micro bleeds show up darker on the scan in these hypoechoic areas. Studies have found 6 times as many lesions with susceptibility weighted imaging as compared with standard MRI. So it's very specific. The traumatic brain injury microbleeds tend to be located in prefrontal temporal white matter and not in the deep gray nuclei of the brain. There's another lesion quantitative report that's coming out. It's not yet FDA approved, but 19 different areas bilaterally will compare different asymmetries in the brain. And then another area of this report is the MRI spectroscopy. It's consistent patterns in traumatic brain injury with the neuronal metabolite N-acetyl aspartate is significantly reduced in the vast majority of studies in patients who have traumatic brain injury. In addition, choline is almost equally found to be elevated in traumatic brain injury. So these measures are really, really, really important, and you're not going to find these on a standard MRI. The glial membrane, which is made of myo-inositol, is often observed to be increased post-injury, and this elevation actually persists into the chronic phase of traumatic brain injury. I'd like to talk a little bit about depression and volumetrics with the NeuroQuant MRI related to the development of depression after traumatic brain injury. So in traumatic brain injury patients who develop major depression, they have reduced volume in the temporal, parietal, and lingual regions compared to traumatic brain injury patients who do not have volume loss. These are major significant contributions to psychiatry to have this scan available and for us to be able to see these regions of the brain. Major depressive patients also with a history of TBI have decreased volume in the temporal region compared to those who had depression without a traumatic brain injury. These findings basically suggests now that the volumetric reduction to the parietal, temporal, and occipital lobes after a mild traumatic brain injury, such as in intimate partner violence, may underlie the susceptibility of these patients developing a major depression, in addition to altered white matter integrity in the corpus callosum and internal capsule. So to have these reports available and to objectively have this data is so valuable in psychiatry.
Oh, yeah, definitely. Thank you so much for sharing that with us, because I think a lot of people aren't necessarily aware of what the newest developments have been recently in terms of neuroimaging, and how much you may be able to capture some of these microbleeds and sort of detailed brain injuries that a vulnerable population such as this one endures.
Absolutely. And just a reminder that single concussive episode can result in global and regional brain atrophy even 1 year after injury. So imagine what repetitive hits to the head may potentially cause long term.
When it comes to multiple traumatic brain injuries and diffuse axonal injury, we know that inflammation is a major concern. What treatment approaches do you know of that are anti-inflammatory that could help this population?
Simply stated, it involves inflammation in the brain. And there is so much that we still do not know and needs to be researched. One of the key thought leaders in bipolar illness, Dr. Roger McIntyre, he perfectly describes bipolar illness as a cognitive disease state due to the brain inflammation, with a disturbance in not only insulin resistance, but metabolics and brain-gut connection. The same is actually really true in traumatic brain injury. It involves a complex metabolic shift in the brain. There's inflammation in cytokines, chemokines, and the microglia. And this pituitary dysfunction was first reported, in fact, in 1918, and the anterior pituitary is damaged. This in turn results in multiple hormone deficiencies, temporary and permanent. So the trauma to the brain is a destruction of the blood-brain barrier, and then the long-term endocrine consequences is what we have to deal with. There's no specific pharmacological therapy currently available to prevent the development of secondary brain injuries. And what we've been looking for are neuroprotective strategies to reduce brain damage. And corticosteroids were introduced in the early 60s, I believe, and the treatment for brain edema. So they were really focusing on decreasing intracranial pressure acutely with these accidents. However, steroids have really become commonplace in the treatment of TBI and assume beneficial effects when used in high doses. And for this reason, they were considered kind of obsolete and potentially even harmful for patients. And in the studies, these results support that and conclude that corticosteroids should not be routinely used in the treatment of traumatic brain injury. They found that a significant increase in the risk of death with steroids and an increased severe disability. So the increase in mortality with steroids in a couple of these clinical trials suggested that the steroids should no longer routinely be used in people who have a traumatic brain injury other than to decrease intracranial pressure acutely. So what do we have then left? We now have and know that hormone replacement in patients with clear evidence of glucocorticoid, gonadal steroid, and thyroid hormone deficiencies have proven benefits, and it's an accepted component of standard of care regardless of the cause of hypopituitarism. So we can look at two of the major steroid hormones, and the first one is progesterone. That's been one of the most studied. We know that progesterone has multiple effects as far as the mechanism of action of inflammation in the brain. It's anti-inflammatory, it's antioxidative, and anti-apoptotic at the cell level. The clinical trials related to progesterone have shown that it is a safe and effective treatment in traumatic brain injury. They've shown with continuous infusions of progesterone that it decreases edema and anxiety and increased activity, thus enhancing behavioral recovery. So we also have seen this using thyroid hormone, specifically T3. A low thyroid production is associated with traumatic brain injury and described in which T4 and TSH levels are in the normal range, whereas T3 is low. However, these patients have a blunting of the TSH in response to the thyroid hormone and suppression of a normally circadian surge of TSH at nighttime and an abnormally high incidence of anti-thyroid antibodies. So once again, the traumatic brain injury patients show a disturbed affect and cognition, and they may be diagnosed with a mood disorder, say, for example, and may show significant improvement clinically with adjunctive therapy of T3 or Cytomel. So in conclusion, clearly there's so much more that we have to learn and so much research that needs to be done on the inflammatory properties in traumatic brain injury. In summary, we know that the neurons in glia synthesize neurosteroids, and in turn, neurosteroids produced in the central nervous system or deriving from the circulation can regulate CNS functions. In the neurodegenerative process of a traumatic brain injury, these neurosteroids can significantly be altered. There is so much with regards to the stress condition and the inflammation that is not clear. However, increasing amount of evidence is suggesting that neurosteroids such as 17-beta estradiol, DHEA, allopregnanolone, testosterone even may regulate neurodegeneration and neuroinflammation. All of these neurosteroids have been shown to reduce microglia inflammation, despite the fact that all of these neurodegenerative diseases involve microglia-mediated neuroinflammation. The final outcome, really, of steroid administration on disease development is different for each steroid hormone model and depends on many factors such as experimental setting, gender, steroid dose, etc. We do know the bottom line that these regulate neuroinflammation, and to replace these neurosteroids in this process certainly isn't treatment modality at this point.
Wow, that is so exciting. Thank you so much for sharing all of this great information with us, and thank you for being on the show.
Thank you so much for your time.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.